Hello, everyone, and welcome to our CRRT workshop. Today is our first workshop in the fellowship, in the Critical Care Nephrology Fellowship, which is structured as 3 modules, 16 weeks each. And we have great speakers today. We have Dr. Kamel Al-Attar. He is the main guest speaker, and he is going to give us very nice background on AKI staging and prescription for the CRRT. We have Dr. Khaled Swifi and Dr. Craig are going to moderate the webinar with Dr. Kamel Attar. Here is our agenda. I'll just give you a small brief introduction about the program. Then we'll play the workshop. Then we'll open the session for question and answers. Then we'll have closing remarks by the end of the webinar today. And we choose critical care nephrology, and we are focusing on CRRT and different dialysis modalities in critically ill patients, because these patients are probably going to have the worst outcomes, devastating consequences, and they are usually challenging cases. And there is a huge management gap, especially between the developing and developed countries, and there is inconsistencies and no consensus in many of these patient strategies and management. So we are really in need to standardize and to have a common ground on how to manage this sick patients. We need also to build up a panel of expertise, especially in the developing countries. So we need to have a good number of trainers with good quality to help the developing countries to establish the CRRT programs and the critical care nephrology programs. And we adopted not only to have a monologue or one-way education, because if we tell you something, probably you're going to forget it. And if we teach you something, you might remember, but we, opted to involve you in the, management strategies and in patient care and during the whole fellowship. So probably you can retain the knowledge and you can apply it in the future. So 3 modules, it's 1 year program. It's really an e-learning education that involves a lot of topics with not only lectures, but also MCQs and also clinical case scenarios, journal clubs, webinars, and workshops. And we have every week assessment and evaluation. And it's very important for all of you to get engaged in the program and to have critical thinking and appraisal. So that's very essential. And we actually evaluate you according not only to your passing scores, but also according to your engagement and active participation during the whole fellowship. As you know, all scientific materials are released every Monday morning, GMT time. So please try to do your tasks and assignments at weekly basis. And the deadline is usually by Sunday night. So it's very important to do it at a timely basis. And all activities are recorded and monitored. So you will get, if you have any insufficient or less than expected performance, probably you are going to get weekly reports on that. And it's not only quantitative, but also qualitative assessment for all of our fellows. We started the program May 20. We finished 2 mini modules. So the first mini module was just an introductory mini module. We talked about critical care nephrology definition, scope, and acid-base disturbances and volume assessment. This was the first mini module. Then we finished the second mini module with AKI, epidemiology, causes, pathogenesis, diagnosis management, and renal replacement therapy in critically ill patients. Then today we have our first webinar. Then for the next 3 weeks, you will have very intense and detailed information and training and education about the CRRT from prescription, indication, timing, doses, and order set, anticoagulation and troubleshooting. So 3 weeks of CRRT. So today, the webinar is just introductory to this mini module of CRRT. Then we will have another CRRT workshop in 4 weeks from now. Then you are going to have the module exam for 3 weeks. So this summarizes the first module. The second module is going to start after you finish the first module. And what's going to happen is on September 9th, we'll start with the shock state with sepsis, septic shock, polytrauma, rhabdo, abdominal compartment syndrome, followed by a webinar. Then we'll talk about multi-organ failure with liver failure, MARS, albumin hemoperfusion, then cardiorenal syndrome, acute heart failure, aquapheresis, and volume control. Then the last mini module of module 2 will focus on nutrition, toxins, and drugs, again, followed by the module exam. And the graduation is dated for May 5th, 2025. So please try to keep the enthusiasm and your active participation throughout the whole year of the fellowship. It's a long route, but probably it's a learning curve, and every day you're going to learn something new. I'm going to stop by here, and I will start playing the first part of Dr. Kamel El-Attar workshop. Then Dr. Craig and Dr. Khaled Suwaifi are going to lead the discussion with Dr. Kamel El-Attar.
My name is Dr. Kamel El-Attar. I would like to welcome you all to the next part of your CRRT prescription training. For this part of the training, we will have a case study simulation where we will have a case. We will try to discuss together the CRRT prescription, implement what you've learned in the theoretical part into the practical case study, then come up with a complete CRRT prescription, upload that prescription on the CRRT machine, and see how that looks like. Be able to judge at the end of the training what's a good CRRT prescription, and to be able to modify the CRRT prescription to be able to fulfill each patient's needs. Good luck with the second part of the training. 100 kilogram, 82-year-old male patient admitted to the emergency room, fully alert, MAP 70, complaining of persistent vomiting and diarrhea with serum creatinine 2.3 milligram per deciliter. We have no history of this case. He passes 400 ml of urine in the first 10 hours after admission. Admitting intensivist, of course, starts fluid resuscitation. What is his current KDIGO AKI staging? Now, using our training, how do we stage AKI using the KDIGO criteria? Patient, creatinine 2.3 milligram per deciliter, does not give us much to do because we do not know history of that patient. Maybe he's been creatinine 2.3 for the past years or the past months. Maybe he's a CKD patient. We don't know the history of the patient. So we have to use the urine output as our indicator to stage that patient using KDIGO criteria. For 100 ml of urine in the first 10 hours. For a patient who's 100 kg, this means 0.4 ml per kg. And then for 10 hours, that means we have a 0.4 for a period of 10 hours. so period longer than 6 hours. This means that this patient is stage 1 AKI according to the KDIGO criteria. If that oliguria persists beyond 12 hours, then he starts becoming stage 2. So right now, the answer for the question is stage 1. 24.
Okay, let's stop by here, and I will let Dr. Khaled and Dr. Craig discuss with Dr. Kamel Al-Attar first the KDIGO staging for the AKI. And do you agree that this patient has stage 1 AKI? So let's start the discussion. Dr. Khaled and Dr. Craig are going to discuss with Dr. Kamel and see if all agrees that this patient has stage 1 AKI according to the KDIGO guidelines. Dr. Kamel, please unmute yourself. Dr. Khaled, do you agree that this patient has stage 1 AKI?
Okay, now I'm unmuted, so that's good. So of course, yeah, I mean,
excuse me, because I cannot unmute. I'm sorry. Yeah. كامل منور. Actually, يعني we have two criteria, of course, the output criteria and creatinine criteria. The urine output criteria, patient making good urine output, so I think a significant AKI. But if you follow the creatinine here, which is important to follow, reaching to 4, it means classically the patient is reached stage 3 AKI.
Okay, but at this stage, I think I agree with Dr. Kamel that the patient still have AKI stage 1 according to the KDIGO guidelines. Of course, the main problem that we don't have a baseline creatinine for him. So we really only have one metric, which is the urine output, to judge on the stage of the AKI. What do you think, Dr. Kamel?
Absolutely, and this case is very common in the emergency room. We get an admission, a guy with a creatinine 2, and we don't know if he's been like that for the past maybe 10 years. Maybe he's a CKD patient with diabetes, hypertension, and is a chronic patient, and 2 is his normal. So it's very difficult in those cases to be able to diagnose the AKI with a solitary measurement of the serum creatinine. That's why the KDIGO criteria is looking more at the trend than the number. Of course, in this case, we assume this is his baseline. We should measure it thereafter and make sure, that within the next 48 hours, for example, he does not have the further deterioration of 0.3 milligram. In the next 7 days, he does not reach 1.5 baseline. Therefore, he would be diagnosed as no AKI patient. But in this case, we have the other parameter, which is the urine output. And the urine output here is not an absolute number. So if 1 liter, 500 cc, the KDIGO criteria looks at the ml per kg per hour. And if we look at this patient, we take how much urine they have produced. We divide it by their weight, in this case, 100 kilograms. And then we divide it by the number of hours that this patient has been in the ICU.
we will be able to see an oliguria defined by less than 0.5 ml per kg per hour for a period longer than 6 hours, but less than 12 hours. In this case, it's a stage 1 AKI. It's important that we all use this criteria as a team, as the doctors, as nurses, as ICU doctors, nephrologists. We all need to speak the same language here when it comes to staging the patients and defining AKI. The beauty of the KDIGO criteria is that it does not have different interpretations. It's just two numbers. And if you can read them clearly, you can definitely be able to define whether the patient has AKI or not, and if he has AKI, what is his current KDIGO staging?
And it's very dynamic, I think. So we have to do very strict assessment, not even every 24 hours, but maybe every 6 hours or so, because this is very dynamic. Patient can move up and down from AKI 1, 2 to 3 very quickly. So we have to be very vigilant, I think. Okay, let's see what's
That's right.
happening.
So it is a track here, and the message from Dr. Kamel is very clear that when you have a patient in ICU and you don't know the baseline ER or whatever, so rely more on the urine output rather than the creatinine. If you want to rely on creatinine, you need to have some time and see the trending of creatinine to.
Correct. Let's keep going with the video.
Stage 2. So right now, the answer for the question is stage 1. 24 hours after admission, CBC revealed hematocrit 36%, hemoglobin 10.3 grams, TLC at 9,400, platelet count at 70,000. Urine output increases to reach 2 liters in the past 24 hours. But serum creatinine rises now to 4.2 milligram per deciliter. A central line is inserted and the CVP is estimated at 8 centimeters water. But his MAP drops now to 65 millimeter mercury. What is his current AKI staging? Would you start RRT or would you wait? Using the KDIGO criteria, it's obvious now that the urine output of the patient has increased. Well, 2 liters, the patient was, for example, 100 kilograms in the past 24 hours, does not fulfill the KDIGO criteria for oliguria. Therefore, we have the serum creatinine. And once we have reached the magical number 4, so creatinine is now 4.2 milligrams, we automatically diagnose stage 3 AKI. So using KDIGO criteria, patient now is at stage 3 AKI. Now, problem is patient jumped from a stage 1 after 10 hours of admission to a stage 3 after 24 hours of admission, despite having a good urine output. Patient is still considered AKI KDIGO stage 3 patient. Would you start RRT? Would you wait? Again, this is a very subjective case. It was built to be gray. So we as physicians will disagree. Some of us will start, some of us will wait. What will make us start a patient with these criteria? Well, some of us would say, though the urine output is adequate, I'm seeing the patient jumping from stage 0 to stage 1, I'm seeing the MAP dropping, I'd rather start now before the patient deteriorates further. Some of us will say there is no clear medical emergency here. Potassium looks good, creatinine looks good. Again, central CVP is 8 centimeters, so I probably wait. There is no right answer to that question. The next 6 hours is conscious level.
معلش دكتور كامل احنا ممكن نقف هنا. You can stop here, please.
Yes, Dr. Khalid.
The question here, we need to just discuss the evidence. So does the evidence of doing early CRRT once reached the KDIGO guideline, KDIGO criteria stage 3 is appropriate, or we could wait until urine output will come down or patient have life-threatening indication? We don't want to leave it for the individualized here. We would like to know the evidence. What do you think the evidence is going toward? Should we go for here based on strong evidence, or should we wait based on strong evidence? Also, the audience need to think about it.
Yeah, many audience choose to wait because there is no urgency, and the patient, it seems, still making the mouth. What do you think?
Again, Dr. Amr, I don't want to really to leave it for individualization. So we have randomized controlled trials, AKIKI 1, IDEAL, and START trials, and the 3 trials confirm it clearly that there is no any benefit of having accelerated CRRT versus delayed CRRT regarding the outcome difference in the form of mortality. And the opposite, all the study reveals that doing early CRRT is associated with increased complication, including collapse. Renal recovery also is not better if you do early versus late. Sometimes it's the opposite. If you look at the AKIKI trial.
I agree. What do you think?
So the message here is to dialogue. So dialogue with the patient is having life-threatening condition, or 72 hours oliguria, or if you feel that which you left in the start time, if you feel that for starting dialysis is the best interest of the patient.
Absolutely. Craig, what do you think?
Yeah, I think the important, can everyone hear me?
Yes.
Right. I think the important point here is that dialysis is meant for the indications that will benefit the patient and that will be life-saving to the patient. A lot of the trials that have looked at the late versus early start dialysis, those trials have really made it very clear that you will never withhold dialysis for an indication which is acute, which is life-threatening in the first place. But then as ICU specialists and as nephrologists, we also have to be anticipatory of what will happen within the next 12 to 24 hours. You can't, make a decision if a patient is, for instance, anuric, but there is no indication for hyperkalemia or fluid overload. You have to be, in a sense, so familiar with your patient that you would anticipate that if a patient, for instance, needs large volumes of fluid but is not passing any urine, that you may need to anticipate a start in view of the fact that the patient may become fluid overloaded, or if a patient's potassium is within a normal range when you look at it now, but you have to anticipate that, given whatever the patient is receiving, whether it be oral intake or TPN or whatever the case may be, that potassium may rise very rapidly within the next 12 to 24 hours. So this is very nuanced because, ICU intensivists and nephrologists will tell you that, if they anticipate that things are not going to look good within the next 12 to 24 hours, then it may be better to start early rather than to be woken up in the middle of the night to start an urgent, untimed CRRT session.
Absolutely. Okay. Very good. Let's move on.
Most of them asking.
Go ahead.
Tom?
Yes, sir.
The question coming from the floor that in certain condition like heart failure, like patient overload, or like that. Again, as we mentioned clearly in the START trial, they mentioned clearly that you can start CRT if you feel that it adds the best interest of the patient. So it's very clear indication here.
Very nice. That's absolutely right. Let's move on and see what happened to this patient 6 hours later.
His conscious level is disturbed. Potassium is now at 6.2. The MAP is now 60. CVV is still at 8 centimeters water. Decision has been made to start CRRT. CRRT is commenced with a maximum blood pump speed of 140. You cannot reach more than 140 because of limitations of the axis. Now, your job is to design a full CRRT prescription, including the modality, the dosing, the anticoagulation, fluid removal, fluid choice. Using your previous training, you should be able to have a full CRRT prescription. I'll give you a few minutes. We'll get back to you to see how a model CRRT prescription looks like, and then we will upload that prescription to the machine. Good luck.
So, does everybody agree that this patient now with hyperkalemia, oliguria, needs dialysis and progressing AKI or not? What do you think, Dr. Khalid? And Craig?
Maybe I will comment. So definitely you're looking at a very acute indication in the potassium being 6.2, and more so in the fact that the patient is almost anuric or oliguric at this stage. So there is no way of moving potassium out of this patient if the urine volume is extremely low. You know, you might want to attempt shifting potassium from extracellular to intracellular spaces, but you will find very soon that for instance, in an acidotic state, that, you know, the moment you shift, you would have to anticipate that potassium will shift back from the intracellular into the extracellular spaces. So purely on the basis of a persistence of the anuria or oliguria and the hyperkalemia, this is a very good indication to start a CRRT therapy.
What do you think, Dr. Khalid?
Yeah, I do agree with
Very
Craig
nice.
and Kamil.
Okay, so now the patient is going to start the CRRT, and let us see the most important question right now. What would be the best CRRT prescription? And I think Dr. Kamil Attar is going to help us to understand what is going to happen, how the initial CRRT prescription and dialysis initiation can be done.
When prescribing the CRRT prescription, usually physician will start with the blood pump speed. Our case, it's a mandatory 140 ml per minute. So this is the best blood pump you can get because of the access. From there, you try to find the dosing. What's the right dosing for CRRT in this case? Using the KDIGO criteria, we prescribe 30 ml per kg per hour to try to achieve 20 to 25 ml per kg per hour. 30 ml per kg, patient is 100 kilos, 30 times 100 is 3000 ml per hour, means 3 liters per hour. Now, 3 liters of what? Infusate, dialysate, or UF. Most of you opted to a UF 0. This patient does not look overloaded. So most of you prescribed 0 ultrafiltration. We're left with 3 liters of prescription. Are we going to use dialysate or are we going to use replacement? Convection versus diffusion. Now, according to your theoretical training, of course, we use diffusion mainly to move small molecules. To remove large and middle molecules, we try to use convection. So in some cases, maybe some of you prescribed 3 liters per hour, 1.5 liter dialysate, being mainly a small molecule problem, and another 1.5 liter of replacement. Some of you made maybe half of that as pre and half of that as post-dilution. How do we make the decision between pre-dilution and post-dilution? Well, pre-dilution, you have the advantage of the blood coming into the filter quite thin, and therefore you have less likely for clotting. Post-dilution, you make the decision built on efficiency. So what do you want right now for this patient? You want more efficiency or you want less clotting? Therefore, given this case, some candidates prescribe maybe 0.75 pre, 0.75 post-dilution. Most of you prescribe 0 heparin for that patient. Why? Because the platelet count is 70,000. Most of us would be very careful prescribing heparin. Some of you prescribe half dose heparin. For that example, we will go with the 0 heparin prescription. Also, dialysate choice. What is your fluid choice? Some of you prescribe potassium 0, some of you prescribe potassium 2, based on the case of the patient being hyperkalemic potassium 6.2. Most of us opted to a potassium 2 or a potassium 0 fluid. Now, Implementing that prescription on the machine, remember blood pump 140, dialysate 1.5 liters, pre-dilution 0.75, post-dilution 0.75, zero heparin prescription, and potassium zero fluid. When implementing that on the machine, we will be able to judge whether this is a high clotting risk prescription or a low clotting risk prescription. We will be using filtration fraction to judge whether it is a filtration fraction that's more likely to clot, with filtration fractions above 25% in fully heparinized patients, but above 20% in non-heparinized patients, like the one we've just prescribed. So we will try to target to achieve less than 20% filtration fraction. What is filtration fraction? Filtration fraction is a ratio that will be calculated by the machine. You will see the results for self. It takes in account how much you use UF, 0 in this case, how much you use pre-dilution, 0.75, how much you use post-dilution, 0.75, what is your blood pump speed, 140, and what is the patient hematocrit, which is 36%. With all these calculations in a built-in formula, the machine will show us what does that prescription look like on the machine itself. Let's see. Now the nurse has received the doctor's prescription, and now it's the time to implement that prescription on the CRRT machine. The purpose of the exercise is to try to see how those parameters will reflect on the actual CRRT prescription. This starts by entering the blood pump speed, as we remember, 140. And then pre-blood pump, if you can remember, 750. Dialysate 1.5 liters. Replacement, which is post-dilution, 750. Patient fluid removal, as we can remember, was 0, but also confirming all parameters. Heparin, 0 heparin prescription. Remember, this is the heparin pump. Nurses can prescribe the heparin with a number of international units per hour. Some of you prescribe 5 international units per kg per hour. In our patient case, that will be 500 international units per hour. And therefore, the nurse will prescribe this heparin using the heparin syringe, entering it here, depending on how much concentration of heparin, maybe 1 ml, 2 ml per hour would be the right dose to be administered through the heparin pump. But in our prescription case, it was 0 heparin prescription, so we confirm that there is no heparin on this one, confirming all. Then, and this is how your final CRRT prescription looks like: blood pump 140, pre-750, dialysate 1.5, replacement 750, 0 UF, and the heparin as 0 heparin prescription. Of course, also using 0 potassium solutions, the dialysate or the hemosol, whatever solution you have as 0 potassium, would be completing your prescription for this patient. Continue and start the CRRT prescription. You can see that this is how the main screen looks like in our case of your prescription. You will see the patient's weight, again 100 kilograms. You will start the CRRT in CVHDF mode. See the blood pump, pre-dialysate replacement. This delivers a dose of 30 ml per kg per hour, which is a sufficient dose, as we explained before. But the filtration fraction, as you can see, is very high at 26%. Remember, patient is 0 heparin prescription with filtration fraction 26% being above 25%. It is a very high risk clotting prescription. This prescription is probably going to clot and will possibly not continue for a 24-hour CRRT prescription. 12 hours into.
Okay, very good. I think dialysis prescription. And what do you think, Dr. Craig and Dr. Khalid, about this dialysis prescription?
Okay, can I start? Because we've got a couple of questions here. A very important comment that one of our participants has made is, before choosing modality, doctors, do you think you need diffusion or convection or both? So I think very importantly, when we're starting CRRT therapy, that is quite a crucial question to ask yourself. You know, you're starting CRRT therapy for certain indications, which may include your acute indications like acidosis, hyperkalemia, and so forth. But there's also a background patient where you want to make a decision: is your patient extremely septic? Is your patient non-septic? And then, of course, the very important thing here is how coagulable is this patient? Is this patient somebody who is likely to be a very high clotting risk? These are very important issues to address even before you think of what modality and how you want to start, because how coagulable your patient is to a very great extent going to determine not only the anticoagulation that you're going to use, but it's actually also going to determine how much of convection you can use. Because if your patient has got a very normal or high platelet count, for instance, and has not been receiving any prophylactic anticoagulation, and maybe has a very high hemoglobin, that kind of patient is going to be very, very prone, especially in a septic state, to clot the filters. And you then have to be very selective about using, as Dr. Kamal says, if we're choosing a non-coagulation or zero coagulation protocol, then you really have to think very carefully about putting this patient on any a high amount of convection therapy, because that is going to have a big effect on the filtration fraction. And you may then, you know, be starting a therapy that is not going to last you very long and really just going to cause you more problems than not. The opposite of that is true if you have a patient, for instance, who has a very low platelet count, whose hemoglobin is not maybe that high. This patient you would label as being slightly, if not at all, but at least slightly less possible to coagulate your system very rapidly. And therefore you may comfortably begin to think of using more convective treatments rather than just diffusion. So for instance, using CVVHDF or even CVVH if you choose to do that.
Very nice, very nice. Let's start, let's go one step back and let's ask Dr. Kamel about the QB, the blood flow rate. I know that initially when you started the CRRT programs, used to use a very slow dialysis flow with QB of 80 or whatever. Are you still recommending? So if you have a good access, I know that the impact of the QB on the hemodynamics is very, very minimal. I think that has been proved in several studies. Are you still recommending starting slow and going up, or can we start with 150 or 200 ml per minute? What do you think?
Thank you, Dr. Amr, for this question, because I've also been seeing that confusion in the group, on the WhatsApp group, that a lot of people are confused about the right blood pump speed for a CRRT prescription. And as Professor Amr mentioned clearly, this idea about the increased blood pump speed ruining the hemodynamics is kind of conveyed from one person to the other without any evidence proving that higher blood pump speed will end up with lower blood pressures. Allow me a couple of minutes to clarify that statement. We're taking the blood from the patient, from the venous side of the patient, returning it also to a venous side of the patient with a certain blood pump speed. So, for example, blood pump 100 would take it at 100 ml per minute, but also return it at 100 ml per minute. So in this case, it's a closed circuit. The patient's 5 liters of cardiac output are not interrupted by this process. So this is an independent circuit that's around 200 or 300 ml. And that circuit is running at a speed of 100 or 200 or 300 ml per minute. So in that case, we are not interrupting the patient's actual cardiac output. In that case, patient's hemodynamics are intact, so there should be zero effect. Now, some of you would argue that, for example, we have a very high dose vasopressor. So if you're implying, for example, 0.5 mic per kg per minute or 1 mic per kg per minute, in those cases where you have high dose vasopressor, it is possible that when you are increasing the blood pump speed, there is a little bit higher clearance for the small molecules, including the norepinephrine, which is, by the way, a very small molecule. In that case, so the advice, what we train the nurses to do, is to take it easy gradually in takeoff and in landing. When you're starting the treatment, you go on gradually from, for example, 100 or 80 to 100 to 150 until you reach the final blood pump speed, and then you stay at 180 to 100, whatever you feel that you have achieved the proper filtration fraction with. So the right blood pump speed is the right blood pump speed that achieves the proper filtration fraction, meaning below 25% in fully heparinized patients and below 20% in non-heparinized patients. Whether this is 180 or 200 or 160, that number that differs from one patient to the other, depending on how much convection you are doing. And as Dr. Craig said, you are the one making the choice of how much convection you're doing. Some of you here mentioned a lot of convection, like, for example, 1.5 liters or 2 liters of convection in this case, which is a very high percentage of convection for a guy with no real evidence of very large molecules that we want to remove. So in this case, what we're trying to convey with this case is to see the trade-off here in CRRT. The blood pump speed, can you achieve a high one? Yes or no? How much convection? Maybe you want a lot of 2 liters, you want 3 liters, but you don't have a good blood pump. Okay, then anticoagulate the patient. He's not anticoagulated, so zero anticoagulation. So there should be a trade-off. You should give something in order to achieve something. And this is what we will also try to explain by the end of this case, is that eventually, as a trained physician, you should be able to make CRRT prescription trade-offs, be able to make sure that you are achieving a good dose, but also with a low clotting risk prescription. So the answer to the blood pump speed, it is the lowest blood pump speed that can achieve the proper filtration fraction.
Very nice, very nice. Thank you so much. And you know me that I love citrate. And I heard good news about citrate application dissemination in the Middle East. Can you please comment on the use of citrate and its importance as anticoagulants on the CRRT, especially if there is no an absolute contraindication to use it, which is usually very, very few circumstances that we cannot use citrate.
Okay, can
No,
I comment on that?
Yes.
Just 1 second quickly. So we will be dedicating an entire week to this topic, and that is week 10 of the course. And I fully agree, and I am a believer in citrate, as is Dr. Amr. You know, it really does revolutionize the way you practice CRRT, because if you master the art of citrate anticoagulation, it gives you a lot more scope for using not only higher concentrations, but you then almost nullify the effect of filtration fraction virtually altogether, because within the filter itself, with the amount of anticoagulation you can achieve with citrate anticoagulation, it is just about the only anticoagulation technique where you can nearly exclude filtration fraction and the limits that imparts on you from a dosing point of view, as well as from a convective therapy point of view. So I'm looking forward to you guys getting involved in week 10, and where we're going to really tackle techniques of how to anticoagulate, but more specifically with citrate anticoagulation.
Very nice, very nice. For the sake of the time, I know you guys have a lot of questions and a lot of comments, and there is a lot of issues we need to address. Again, this is just an introductory webinar, and you are going, as Dr. Kirk said, to have 3 weeks of detailed and intensive training for the CRRT. Then we will have another workshop for CRRT after that. So this is just an initiation and induction. So don't worry. and we are not supposed to answer all the questions, but it's good to have questions. Then these questions are going to be answered throughout the whole CRRT mini module. I'm going
Yeah,
to.
Dr. Amr, just before finishing, I would like really to stress on, because I have been asked many times about it. So physicians and nurses, they have to be familiar with the CRRT standard prescription. We have a standard prescription everywhere, like regarding mechanical ventilator, regarding vasopressor, whatever. So they need to know about the standard CRRT prescription items to be fulfilled. There are 7 items. I'll finish it in 1 minute. The first item will be the mode of CRRT. So what mode are going to use, CVHD or CVHDF. Then the dose of CRRT, which is based on the guidelines around 20-25 ml per kg per hour. Sometimes you reach to 30 just to avoid the CRRT downtime. Then you go for distribution of that dose. You go with mostly as a standard. Initially, you go with 50% dialysate, 50% replacement fluid, and the replacement fluid also you go with 50-50, and later on you can adjust based on the requirement if you are going to do CVHDF. Number 4, you concentrate about blood flow rate, and blood flow rate, as Dr. Mentioned clearly, that important to look at the filtration fraction and should not exceed 20% by all means to allow the filter to stay. But important also to look at the hemodynamics, and if the hemodynamically unstable patient usually start low and we go slowly up. 80 ml per minute is the standard, and then you go to 200, which is the target. If you don't able to reach 80 ml per minute because of the filtration fraction, also of the hemodynamic issue and all stuff, you need to have saturate here to preserve the filter. So it's the only way to continue with 80 ml per minute is, or 80 ml per kg per minute is actually the citrate. Then you go for the ultrafiltration flow rate. So how much ultrafiltration you need to have, which depend on the volume status of the patient. Usually we start with 0 fluid removal, and then you go higher based on the patient condition. And then what anticoagulation, 0 anticoagulation. Mostly we are using 0 initially, fine. Sometimes the hematoma issues or whatever, and later on you add heparin or not based on the patient condition, or citrate based on the patient condition as well, and the experience of the cell or the cell. Then finally, you have to mention clearly that we need to adjust the dose of antibiotic, and they adjust the nutrition as well. It's the last thing to mention, as that nutrition and antimicrobial has been reviewed, because now you have a CRRT which can clear most of the drug you are using, which is crucial for septic patient. Nutrition also not able to use full nutrition support. Now you can use full nutrition support. This is the 7 items you need to fulfill, and then later on you play with the conditions of the patient. Thank you.
Very nice, very nice. Thank you so much, Dr. Khaled. And let's move on, and we'll have more and more details in the next 10-15 minutes. So please stay with us.
Prescription. This prescription is probably going to clot and will possibly not continue for a 24-hour CRRT prescription. 12 hours into CRRT, his labs are out. Serum creatinine is now 2.6 milligram per deciliter. Serum potassium is 5.5. What changes to the CRRT prescription would you make? In 12 hours of CRRT, serum creatinine dropped from 4.2 to 2.6. For me, this looks like an amazing clearance. Clearance is good of small molecules. Potassium dropping from 6.2 to 5.5. Remember, in CRRT, we target correction of the electrolytes over 24 hours. So when we achieve that results in 12 hours, it seems like a good result. For me, I'll probably change nothing. Some of you opted to go from potassium 0 to potassium 2, which is not a bad decision, in this case to try to prevent hypokalemia, which is a complication of CRRT usually seen in prolonged times of CRRT or very high dose CRRT. At 18 hours of CRRT, patient develops a fever and a tachycardia with a heart rate 110. His MAP is now 60. What changes to the CRRT prescription would you make? Remember, our CRRT prescription blood pump speed was at 140. We were using 1.5 liters of dialysate. We were using 750 of pre and 750 of post dilution. We were using zero heparin prescription. We were now back to potassium 2. This is the current CRRT prescription. Now, the patient obviously is developing an AKI with sepsis, and the septic condition is worsening. So we're seeing fever, we're seeing tachycardia, we're seeing a drop in MAP. Most of us now would think of doing more convection than diffusion. So you're still using a CVV HDF prescription, but we'll try to use this 3 liters per hour to produce more replacement and to produce less dialysate. Now, this is going to be very difficult with the original CRRT prescription because we are already with a very high filtration fraction. Now, how can we actually reach good convection while maintaining acceptable filtration fractions? So the decision was made by the prescribing physician to increase the convection and reduce the diffusion to try to manage the bigger sepsis problem and the less of the AKI problem. So the problem now is with large middle molecules, trying to remove cytokines, interleukin 1, interleukin 6, TNF. So the decision was to do more convection, to remove more of the big fat elephant molecules in the patient. So we're going back there. Doctor changed the prescription to have 1 liter dialysate, 1 liter pre, and 1 liter post. In that case, having the same dose of 3 liters, but 2 liters of which, or 2/3 of which, being convection, and only 1/3 being diffusion. Let's see how that looks like on the monitor when we enter the prescription. So we go to adjust here, and we start the blood pump. We cannot change that. As we know, the maximum is 140 because of the limitations of the access. We change the pre-blood pump to try to make it up to 1 liter. We try to go to dialysate, reduce it from 1.5 to 1 liter. We go to replacement and we increase it from 7.5 up to 1 liter. So what does that look like? If you confirm all parameters, you will see that the dose is still 30 ml per kg per hour. We did not change the dose, but definitely much more convection and less diffusion. But what's the major problem with that? As you can see, filtration fraction went up to 33%. In that case, it's a very high clotting risk prescription. So when we are prescribing that, we have to already know that either within a few hours we will receive alarms and we will do circuit change, or we can change or adjust something within the CRRT prescription to achieve what we mentioned earlier as 20% maximum filtration fraction in non-heparinized patients. How can we achieve that? As we remember, the formula starts by increasing the blood pump, which we cannot do. What else can we do? Maybe reducing the post-dilution. So if you can see just one step, reducing the post-dilution from 1 liter to 0.5, let's see how that looks like in terms of filtration fraction. We adjust, we cause the replacement, we go to the 1 liter, and we make that 0.5. If you confirm that, filtration fraction will go down from 33% down to 25%, which is a good change. 25% seems to be acceptable. What decisions can we make now? One decision is to fully heparinize the patient. Make the decision that platelet count 70,000 is okay. I can now introduce heparin, give a full dose of 10 international to 15 international units per kg per hour. Patient is 100 kilos. I prescribe 1,000 to 1,500 international units per hour and continue my CRRT. If I insist on doing zero heparin, I need to do further actions to reduce my filtration fraction. Another action is also to reduce the pre-dilution. So the pre-dilution is a factor that reduces clotting. It's also a factor that causes pressure on the filter. So going down from 1 liter pre-dilution to half a liter pre-dilution will reduce the filtration fraction. Let's see that. Adjusting it, going to pre-blood pump, and reducing 1 liter to 500 will also further reduce the filtration fraction of our patient. Now we have reached 18%. This is an acceptable filtration fraction. But look what happened. We went down with the dose from 30 ml per kg per hour to 20 ml per kg per hour, which is not acceptable. As we saw from the KDIGO guidelines, we need to prescribe 30 ml per kg per hour to achieve somewhere between 20 and 25 ml per kg. How can we compensate for that reduced dose of CRRT? Well, we can increase dialysate back again to 2 liters. So compensating the half liter we took from the pre and the half liter we took from the post and put it all in the dialysate. We adjust, we press dialysate, we go from 1 liter up to 2 liters of dialysate. Confirming that you have achieved 30 ml per kg per hour with filtration fraction of 18%. Now, some of you are going to say, well, we reduced convection. You did not increase convection. You ended up with the right dose, but instead of increasing convection, we end up reducing convection. So what is the answer to that? The answer to that is that the CRRT prescription is more of a science and an art than a statement. So that means that in order to reach good convection, you need a good catheter in a patient who is 100 kilos. So you have to either have a perfect access, then you can play with the convection as much as you want, or a smaller patient, which we do not have, or a less hematocrit, which we cannot control. So in this case, what we can control is the CRRT prescription, and it's a trade-off. You want high quality convection, at the same time less clotting. You want to have a good clearance of large molecules, but you want to have a filter that stays for 24 hours. Which is more important right now? You need to make your trade-offs built on the parameters that we explained in our practical session today and in your previous theoretical studies. Good luck with the rest of your CRRT training. Again, my name is Dr. Kamel Attar. I wish you all the best of luck.
Very good, very good. That's really amazing. And it opened again the floor for a lot of discussion. And by the way, we have Dr. Marcos and Dr. Ricardo with us, and I would love to hear from them. And let me just ask a very naive question. So when you elected, and I think most of you guys are going to do the same, to increase the convection with the blood pump, because of the patient condition with sepsis, what is the evidence that increasing convection is going to improve patient outcome? Do we really have a good evidence on this? And I know that when you remove these cytokines and interleukins via the convection, it's not selective, because not all of these cytokines and the interleukins are hazardous or deleterious to the patient. Actually, they would be compensatory. They change from adaptive to maladaptive with increasing numbers, and they are working very hard, I think. But the initial response of our body is to increase these cytokines and interleukins as a compensatory mechanism. So how would you manage the situation? What is the real evidence beyond increasing convection in this patient and removing more cytokines would improve the patient outcome?
Okay, I'll comment to start off with. There is really no very high level evidence where large volumes of patients have been randomized to either the use of purely diffusive therapies versus purely convective therapies. So if you're looking for the study where you have 200 or 400 patients on either side of a randomized controlled trial who are equally sick in the same phase of their septic illnesses, and whether the difference between convective treatment is in fact better than just diffusive treatment, you will not find that study has not been conducted and has not been conclusively. There has been no conclusion as to the superiority of CVVHDF or H over CVVHD. However, I just, and this is a very, very long topic, and there's a lot of discussion around this, but I just want to emphasize, as a nephrologist, convection is not a myth. Convective therapies is not something that we have made up as ICU specialists. It is real. It is the transference of toxins across a membrane rather than diffusive movement of small molecules by concentration gradient. And depending on the size of membrane pores, you can only remove certain molecular sizes based on convective therapies. So whether convective therapy really does do what it's said to do, yes, it does, but we may not have yet the right tools to really measure exactly, what the differences are between these patients. And I think that is where the science is letting us down at this point in research, is that we, first of all, cannot conduct very large studies on these patients. They are not, it's not a kind of question that you can clinically just find 800 patients and have 400 in each arm. And then secondly, I think it's very difficult, if not impossible at this stage in our science, to measure exactly, well, first of all, we don't know what we're measuring, which is going to make a big difference in one patient over another patient. And then we don't have ways of measuring the differences between them. That's my personal opinion.
Thank you so much. Dr. Ricardo, what do you think?
First of all, I have to say that I don't want to confuse people, but we use different kinds of machines. We have basically two general principles, convection and diffusion. But the machines and the software of the machines, it's not always equal. So we have certain kind of machines who the software give more importance to convection, and there are certain machines and certain software where diffusion is more important. And so you have to know well your machine and use it according to the machine you have. I remember from the past that in septical patients, certain groups start to use doses not of 30 mils kilo, but they arrive to 60, the double of the dose. And they say, even strange, the fact that some of those patients septic are hemodynamically unstable. What they saw is that with the reduction of cytokines, the patients become more stable and have better outcome. That was not true. So in my opinion, in my practice, there's no benefit in using such supernormal doses. So with 30 mils or 35, it's more than enough to treat our patients and to not to stress so much and avoid some risks. The other point is that physiopathology and the size of the molecules, I think it's also important. But of course, we never know, until now, we don't know what kind of molecules we want to remove. And we don't know if we are able to remove only the bad cytokines and stay with the good ones, or if we remove both in different proportions. But of course, we know that convection is related with some size molecules, and diffusion is related with a different size of molecules. And in the septic patients, it's good to remove large molecules. That was also the point for those who develop certain kind of filters. I have to say, I have no particular experience in using filters dedicated to remove cytokines in sepsis. And as far as I know, there's no clear, effective evidence of benefit on using those filters. But some groups who use it have a good experience, but we need to do RCTs. We need to have studies, quality studies, large enough, multicentric studies to show the evidence of the benefits of those kinds of devices. That is my expertise in the field.
Very nice, very nice. Thank you so much, Dr. Ricardo. And yeah, I see a lot of question about Auxerius filter. I don't think we will have enough time to discuss, to open, this for discussion right now because it's a very controversial issue. I think Dr. Kamel Attar next webinar can give us, up-to-date information about the value. We need, metrics. We need objectives. We use it, of course, in a lot of patients with, septic shock for cytokine removal. And also during the COVID era, we used it a lot. But we need, good evidence if this is going to not only remove the cytokines, but also to improve the patient outcome, especially the mortality, the hospital stay, the AKI, and so on. So we have 1 minute to close the meeting, I think. So I will let Dr. Khaled, Dr. Craig, Dr. Kamel to give final closing remarks. And of course, for the fellows, please don't panic. This is just an introductory session. It opened the whole CRRT for discussion, but again, you're going throughout the whole year of fellowship to get more and more information. And I promise you, you're going to master the whole thing by the end of the fellowship. Dr. Kamel.
So again, it's a very nice, as Dr. Ahmed, this is not it, this is not the training, but it's just an introduction, like what we will be doing during the training. So the idea is after you finish the course, you yourself will be able to, for example, calculating filter, the different modalities and being able to do that yourself. So it's a good introduction. I like what this call is very impressive is the discussions. I like it very much. The chat has a lot of questions, very good ones. We did not answer most of them, but hopefully we can in the next sessions answer about the weight of the patient, about anticoagulation. We saw stuff about hemoadsorption, as Dr. Amr said, training itself. But definitely a much more interactive session than last time. I hope we answered some of the questions, and we will have the chance to answer more. Thank you, Dr. Amr.
So much, Dr. Craig.
Yeah, I think with this whole entire topic, a lot of this, in terms of speaking about numbers and speaking about dosages and speaking about the different modalities that we do, it takes a bit of getting used to, number one. And I think it takes a bit of practice. It takes a bit of practice by, being able to manipulate numbers and so forth. So I think you guys are in for a very detailed and interesting next month or so, because I think between myself and Dr. And between the other consultants, we've really put together a few good series. So I agree with Dr. Ahmed. Don't panic. It's going to be, we take it one bite at a time, from blood flows to dialysates to post and pre and anticoagulation. It's better to understand each and every aspect in its individuality and then put it all together like a big puzzle. So I'm looking forward to interacting with you guys.
Very nice, very nice. And we'll keep discussion through the WhatsApp group, and also in the platform. You'll get more and more discussion and questions, and with your engagement and active participation, I think we are going all to learn together. So some of your questions we are going to collect them, and we are going to discuss them either privately or in the group. And I'm very sure that most of this question will be answered throughout the whole month, but we'll open, these questions and your concerns for discussion in the WhatsApp group in the next week. And of course, our next scientific materials and scientific contents are going to be released on Monday morning. We're going to start with the first week of CRRT with Dr. Khaled. Then the next week will be with Dr. Craig with anticoagulation. Then the third week will be again with Dr. Khaled with the troubleshooting. Then we'll have another workshop with Dr. Kamel Attar in a month from now with the second CRRT workshop. Thank you so much for your participation. And I'm hoping that all of us learned a lot today, and we're going to learn more and more. Thank you.
Thank you.
Thank you, everyone. Have a nice evening. Bye.
You too. Bye.